Ventricular escape and idioventricular rhythms. We're going to identify the origin of idioventricular rhythms in the cardiac conduction system, recognize idioventricular and ventricular escape rhythms on the ECG monitor, define the inherent firing rate of the ventricular pacemakers, and explain why idioventricular rhythms always have wide QRS complexes. So ventricular rhythms occur when the ventricles are the only pacemaking site for the heart. So if you remember in the previous lecture, I asked the question, what happens if the ventricular fail-safe pacing fails? And essentially, the patient dies. There's no backup for this. They can occur as escape rhythms, or they can occur due to increased automaticity of a single ventricular ectopic pacemaker. The ventricular escape pacemakers are the last line of defense for the heart when it comes to maintaining function and cardiac output. The morphology is typical for ventricular complex, meaning that it's going to be wide and bizarre, but because it is a ventricular escape and not a premature ventricular contraction, is going to arrive late instead of early. So ventricular escape complexes can occur singly or they can occur in pairs, as illustrated here. Now, if you note, there is P waves occurring at a regular interval, but they're not capturing these ventricular complexes. If over 3 of these escape complexes occur sequentially or back to back to back, then it's called an idioventricular rhythm. The P waves can be present with ventricular escape complexes like I just mentioned, but the supraventricular P wave failed to conduct to the ventricles, and the supraventricular P wave may be a retrograde P wave from the ventricular escape complex itself. Multiple ventricular escape complexes are usually associated with AV dissociation or a block at the AV. If the AV node fails, then the ventricles will develop escape complexes to attempt to maintain cardiac output. So we'll talk about the idioventricular rhythm, then we'll talk about the accelerated idioventricular. So the idioventricular rhythm is going to be the pacing rhythm of the ventricles. The intrinsic escape rhythm from a ventricular foci that has increased in automaticity and developed because it's not getting communication from the top of the heart, and so it's saying, hey, I need to pick up and start pacing myself. So what you're going to see are wide complex in morphology, ventricular complexes, and you're going to see a rate between 20 and 50 beats per minute. So here's an example of an idioventricular rhythm. Assuming this was a 6-second strip, you've got a rate of 40, but you've got wide QRS complexes, no P wave. So there's no P wave that is capturing these complexes. With an accelerated idioventricular, this is going to be the same rhythm, but now the rate is greater than 50, but less than 100. So between 50 and 100. Accelerated idioventricular rhythm is caused by an increased automaticity of an ectopic ventricular pacer. The complexes have the morphologic characteristics of the intrinsic ventricular rhythms, wider than 0.12 seconds, a bizarre appearance, and the ST segment and T wave abnormalities. This rhythm is typically regular, but there may be some slight irregularity. So this is an example of an accelerated. So you've got a rate of 60, but you've got wide complex ventricular rhythm, and although we can't say for sure, this is just showing an example of you've got a individual ectopic pacer that has increased in automaticity. Now, sometimes you can have a wave that is an accelerated idioventricular rhythm with AV dissociation, and in that case, you're going to see the appearance of P waves that occur, and you may even see a regular underlying P wave, but there's not going to be any type of capture. Faster rates in accelerated idioventricular rhythms can lead to more variability in the fusion complexes with the disassociated P waves. So usually when it's a little slower, the P waves are going to be fused in. So capture beat. So essentially you've got the same rhythm that we just looked at, but the way that fourth P wave happened, you've actually got a supraventricular capture now, and so now you've got a narrow QRS, but then it instantly gives rise back to the wide QRS complex. Idioventricular, my rate is 20 to 50. My regularity is going to be a ventricular regular. P wave, if we see a P wave, it's either going to be retrograde or post QRS, or we're going to see AV dissociation where we see P waves happening, but QRSs are occurring on their own. No P to QRS ratio. The PR interval, we don't have any. QRS width is going to be wide. No grouping or drop beats. And then the rules are the same for the accelerated idioventricular, except now the rate is 50 to 100. Several different things that can cause it. It may be due to increased automaticity, or it may be due to an escape mechanism reflecting the failure of the supraventricular pacemakers. The majority of these are symptomatic, because if they are from the pacer of the ventricle, then the rest of the heart has failed. And even if there is a block in the conduction from the supraventricular ectopic area or the supraventricular electrical conduction, the ventricles still feel as if though they need to pace, and so the only cardiac output that's occurring is from the paced ventricular beats. So it's going to be much lower typically. So we're going to look at a couple of examples. So my rate is around 50. It's regular. My P wave. So my P wave is actually retrograde, which means that it's post QRS. Now the reason why I know this is retrograde is because it's occurring in a regular interval, and you've actually got a regular RP interval. Now it's wide, but you do actually have an RP interval. My QRS complex is wide, and this rhythm is at a rate of 50 is an idioventricular. My rate is 50. I've got wide complexes that are regular, idioventricular. My rate is 50. Now I mentioned Josephine's sign earlier, and there's possibly that since it's occurring regularly. But again, we're not trying to really identify if there is a P wave in this, because we see that it's a wide complex and it's a rate at 50. And if this is clinically what we're seeing in our patient, that's going to be a moot point. So we've got another idioventricular. Wide complex with a rate of 70. So we've got accelerated idioventricular. Same thing here at a rate of 80, accelerated idioventricular. So one thing to note about this, the QRS complex is pretty small. So this is not your QRS complex. This is actually an elevated ST segment. So this actually is going to be a accelerated idioventricular with an elevated ST segment. So this could very well indicate this patient's having an AMI. And then this one, our rate is 80 beats per minute, so it's accelerated. And lastly, if you note here, you do have wide complex QRSs. They're very low in amplitude, so they're not very strong, but they do have a rate of about 80, and it is regular. So this, again, is accelerated idioventricular.